Okay, so we might kick off in the interest of time. So on behalf of Northwestern Melbourne Primary Health Network and Eastern Melbourne Primary Health Network, I'd like to welcome you all to our COVID-19 vaccination rollout forum. My name is Bianca Bell. I'm the Director of Primary Healthcare Improvement here at Northwestern Melbourne Primary Health Network. This is actually our second in our COVID vaccination series. So for those of you who attended last week, welcome back. And that session was a bit more of a clinical look at the vaccination and is available on the PHN websites if anyone missed out on that. Really appreciative that so many people have given up their time tonight. Appreciate that it's a very busy time in primary care, so really glad that you've been able to join us. So before we officially kick off, I would just like to acknowledge the traditional owners of the lands on which we're meeting today and pay respects to elders past, present and emerging, and pay respects to any Aboriginal elders here with us tonight. Just a little bit of housekeeping. I'm sure we're all very familiar with Zoom and the do's and the don'ts, but just a bit of a reminder, we do, it would be great if everyone could remain on mute except when speaking. Would be really great to see as many of your faces as you can, so don't be shy, please turn on your video, and if you click on your video and see that actually it's coming up as, you know, Bianca's iPad or something like that, please feel free to change your name, and you can do that by pressing on the 3 dots on your profile pic. We do have allocated question time after each of our speakers, so we would encourage you to come off mute, ask your question or use the question and answer function. And we'll be asking a mix of the questions that were submitted when registering. So thank you to all of those who put in those questions, and also trying to get some interactivity happening as well. Please note that this session will be recorded. So if you don't wish to be on, then, you know, please feel free to leave your camera off. So some really exciting news to share quickly is that the vaccination pathways, are now live on the Health Pathways Melbourne website. So there's a preparing for COVID-19 vaccination page is now live as of today, which is great. And this is a fantastic addition to the suite of COVID-19 pages that have definitely been the sort of most looked at pages, definitely all of 2020 and to continue to be. And it's a great a pathway that really sort of looks at those practical aspects of implementing the vaccination within your clinic. So I encourage you all to jump on. If you don't have access to Health Pathways, please feel free to reach out to the relevant PHN and we'll be able to set that up for you. So we have a really jam-packed, exciting agenda tonight, and it's going to be a really interesting session, I'm sure. So it's structured a little bit differently to some of our previous education sessions. It's much more of that sort of town hall style. The presenters will provide a bit of an update and then there'll be time for questions. So really want that interactivity. I do want to say a special thanks to all of our panel members online. It's fantastic that you've been able to you know, willing to give up your time tonight, and great that we could get so many of you here. So just a brief run through of the agenda tonight. So we'll have Janelle Devereaux, who's the Exec Director of Health Systems Integration at Northwestern Melbourne Primary Health Network, and she'll provide a bit of a current status as to where things are at with all things vaccine. We're then going to have Dr. Lucas de Toca, from the Department of Health, to come and talk about the COVID-19 primary care response. We're also joined by Janine Trevillayan, lead of the COVID-19 vaccination program at the Austin Hub, and Finn Raman from the Western Local Public Health Unit. We are also joined by Andrew Lowe, who is the COVID-19 vaccination operator for Aspen Medical, who's going to talk to us about the rollout of vaccines in residential aged care facilities. We then will have Narelle Quinn join, who's the Exec Director of Program Delivery and Service Enhancement, and her and Janelle will just touch a little bit about the PHN support, and then Narelle will be wrapping up the session. I do just also want to introduce you to Dr. Jeannie Knapp. Jeannie is a GP at Church Street Medical Centre, and also I neglected to put on the slide, the GP advisor at Northwestern Melbourne Primary Health Network. So Jeannie will be helping moderate the questions tonight for us. So a big thanks to Jeannie, and also just to acknowledge the staff from Northwest and Eastern Melbourne PHNs who are online. I will now hand over to Janelle to provide a bit of a brief snapshot of the current state of play re vaccines.
Thank you, Bianca, and welcome to you all. It's great to see so many people dialing in or zooming in, and also just another thank you to the panellists who have given up their time this evening. I'd also like to just acknowledge that I'm zooming in from Wurundjeri country and pay my respects to elders past, present and emerging. Now, this is a fairly busy slide which we can make available to you, and a lot of the detail within it you can actually hear from panellists, and given how quickly things are changing, you may well get some updated information from the panellists, so I won't take up too much of your time, but I just want to give a brief update on the current status of where we're at with the vaccination immunisation program at the moment. We're fortunate to have in metropolitan Melbourne 3 vaccine hubs that have been established in line with the new local public health units at Western Health for the Western Metro cluster, and I'm sorry there's a missing N on that sentence there, the Austin Health for the Northeast and Monash for the Southeast cluster. Vaccinations commenced on the 22nd of February, which feels like a long time ago already. And as of yesterday, advice from State Department of Health was that approximately 5,000 doses had been delivered across Victoria, excluding private aged care, which is a huge achievement in a really short space of time. You will have seen in the media too that there is additional AstraZeneca vaccine doses available, and they will be coming to states and territories in due course. And just really to let you know that the PHNs are working in partnership with the vaccine hubs at both a working group and a governance level to make sure that we can keep primary care informed and support any coordination of activity across our region as we learn more as the program rolls out. In relation to primary care, as many of you will know, the expression of interest process is complete, and in due course shortly, this week, we're hoping to be able to get further information out to those eligible practices in terms of induction and how to get the ball rolling to prepare your practices for providing the vaccine. Our role really to support general practice is supporting that readiness, including facilitating the EOI process, but also running these webinar sessions and making sure that we have up-to-date health pathways, resource information to support you in practice in time. And of course, we've got some great comms teams at both the PHN that are keeping you in the loop with the information as it becomes available to us. In terms of residential aged care facility rollout, this sits with the responsibility with the Commonwealth Department of Health and with Aspen contracted to deliver the vaccine, which commenced also from the 22nd of February. We're really helping residential aged care facilities to be informed about when they're scheduled, make sure they've got access to information to prepare for vaccine rollout, connecting with primary care staff that support residents of aged care facilities, and supporting again any coordination with local hospital, residential and reach services where needed. Some really fantastic outcomes already in terms of more than 1,700 residents being vaccinated across both northwestern and eastern Melbourne catchments, and approximately 90% of residents being vaccinated. So that's fantastic to see so early in the program. And the last thing I just wanted to mention was in relation to some research being undertaken by the Murdoch Children's Research Institute in relation to, community views and intent on vaccination. And what we're starting to see, what we were advised yesterday, is that we're seeing approximately 60% of the community intending to vaccinate, with around about 25% of people feeling hesitant about that. The greatest concerns really relate to safety, and I think a lot of that is driven by the conversation around the speed with which vaccines have been developed, also the dialogue around efficacy, and really people just want to understand how these new vaccines work. And this research gives us some insight as to what we can do to help build confidence in the community about receiving the vaccine, and also has identified some populations that may be less willing, and that includes females, Indigenous Australians, people who speak a language other than English, and those that have not completed Year 12. And I guess really that means that it requires really targeted communication and engagement with trusted sources. And PHNs, we're playing a role in supporting the dissemination of consistent evidence-based and accurate information to local communities and across the region, but also importantly, actually what we're hearing from communities across our regions, we can help feed back into state and Commonwealth governments to support those communication strategies. So a lot of work is being done, certainly I know at state level, and there's been a lot of resources developed from a Commonwealth perspective, and we'll be doing some work locally to make sure that that really meets the needs of our local communities. So that's a very quick snapshot from me, but I won't hold things up because I'm sure we would like to hear from the others on the panel. So thanks again and for joining us, and I look forward to hearing the questions later in the evening.
Thank you, Janelle. I'm just going to stop sharing my screen now and welcome who I believe has joined us. Oh, yep, I can see you on the screen there. Dr. Lucas Toca from the Department of Health. So thank you so much for joining us and zooming all the way in from Canberra. So we might just hand over to you, Lucas, to, I guess, begin with a bit of an overview of the Commonwealth response to COVID vaccination, and a real focus on the general practice rollout.
Thank you, Bianca. Sorry I was late and I missed the beginning, but I really enjoyed Janelle's overview. Yeah, Lucas Toca here. I'm in the Department of Health in Canberra. I help coordinate the Commonwealth's primary care response to COVID-19. So for over the past year, we've been with our partners in EMPHN World and the colleges and the other players in the primary care space have been helping coordinate the GP respiratory clinics, the distribution of PPE through the PHNs, and all the elements of the response that relate to the primary care parts of the health system. So now we've pivoted a bit to also help coordinate the vaccine rollout through primary care, which from the moment phase 1B of the rollout kicks into gear, it will be the cornerstone of the rollout from an Australian government perspective. So as you're all familiar, I'll try to make a very brief intro and just skip straight to the sort of useful and novel information, not just the overview, because you're all familiar with the approach. But I think it's good to remember that the principle here is that the governments, both the Australian government and the state and territory governments, want to ensure that everyone in Australia who's eligible for, everyone in Australia who wants to have a COVID-19 vaccine and at the moment, and is eligible for that, and at the moment that's essentially every adult in Australia that doesn't have a contraindication, has access to safe and effective COVID vaccines, and that access is for free. So when we are looking at how we design the parts of the system, it's to make sure that everyone, no matter what the medical status is, what the visa eligibility is, and where they come from, they can find a place where they can access the vaccine and access the vaccines for free. We talked a lot about Pfizer and AstraZeneca and the different vaccines, and people will have seen the phase rollout in priority population groups. I'm not going to go through the 1A, 1B, 2A, 2B, because I think people are familiar with that after I'm sure many excellent webinars that predate me, and probably more excellent than the one that contains me. But I think it's important to clarify that we are not equating vaccines to phases or to priority groups. It's not the Pfizer vaccine goes to the 1A group because we think it's more suited to that group. It's only a matter of which vaccines we have available, and as soon as they become available to the groups that are prioritized as high as priority from a risk of infection and risk of severe disease perspective. So we anticipated that Pfizer vaccines would come into Australia earlier than AZ as they did, and they received TGA approval prior to AZ, and that's why we keep talking about the Pfizer vaccine commencing on the 1A rollout. But as Janelle mentioned before, we've had a shipment of international doses of AstraZeneca vaccine come on board that we are going to start distributing through our partners in the states and territories from next week, and those vaccines will go to 1A population as well, because the logic is vaccines that are here need to go to those that are targeted. The Australian Technical Advisory Group in immunisation are at highest risk of either infection or severe disease, and those are the populations identified in the priority group 1A. As we move through the vaccination phases, different vaccines will be available in different locations and people will have access to those. It is likely that later on in the year, we might get other vaccines coming into the picture. The Australian government has purchasing agreements with the Novavax facility, which is showing promising results in some of the early clinical trials. If that vaccine is confirmed and then approved by the TGA and made available, that will join the mix of vaccines that are being made available in Australia. So I think the approach that we're following, guided by ATAGI and guided by the Therapeutic Goods Administration and the regulators, are that if vaccines are deemed to be safe and effective for our population, we need to make them available, and we will make them available in the order that ATAGI recommended, is based on risk of infection and risk of severe outcome. We are making choices based on logistics though, and because of the requirements of cold chain and the ultra cold requirements for Pfizer, plus the other difficulties with its handling, we have made the decision that in primary care, AstraZeneca is a vaccine that will be used, just because it's despite the multi-dose vial requirements, it's a vaccine from a logistics, cold chain and storage perspective much more akin to the vaccines that are regularly administered in general practice. That's why we keep talking about phase 1B commencing with primary care and primary care commencing with the AstraZeneca vaccine. But the Pfizer hubs or the hospital hubs that are providing access to the Pfizer vaccine will continue throughout phase 1B and the other phases of the rollout, as again, we need to make sure that as many doses as they are available and as safely as possible are translated into doses in arms as quickly as possible, because our goal is to get the population vaccinated. As you also know, we are banking on direct immunity. We know that both vaccines are incredibly effective at preventing severe disease, hospitalization and death. And that's what we're counting on. We're looking at getting as many people as possible vaccinated so that we can have whole population or whole of adult population direct protection from severe outcome. We don't know the effectiveness of the vaccines in preventing infection or preventing spread. It's very biologically plausible that they will play a role in that. And we have some emerging data from Israel and other countries where they seem to be showing a slowdown in transmission rate because of the vaccination. As I said, it kind of makes sense biologically, but we don't still have conclusive epidemiological data that confirms that the vaccines prevent infection. And that's why the strategy is focusing on that direct protection as opposed to indirect protection and herd immunity. Primary care. I said I wouldn't give a long, boring intro, and then I did. As you all know, we envision primary care to be a key part of the delivery of the vaccine. And as a lot of these things, of course, the approvals, the way the rollout is constrained by the fact that as everything in our lives over the last year, we are dealing with some degree of uncertainty and change in information. The rollout is constrained by whether TGA was going to approve the vaccine or not. It's constrained by how many doses of vaccines we're going to get. And that's why a lot of the time, as we go through the different phases, we want to engage as much as we can so that the policy formulation gets input from and feedback from the people who are actually going to be delivering the vaccine on the ground, so that we can adjust and adapt the policy and the rollout to something that is actually going to work. And that is the approach that we're following on primary care. There was a decision to make primary care a fundamental delivery mechanism and a big part of a cornerstone in the system of the vaccine delivery from phase 1B. And we got a lot of feedback from general practice and other providers in the primary care space that people really wanted to ensure and that they could administer the vaccine to their own patients and that people could access the vaccine from their own GP. And that's something the ministers made a commitment to, that especially the 1B population, people who are elderly, older people, or people who have underlying conditions, as much as possible access the vaccine from their own GP. And the only way that we could do that was to go as broadly as possible. So we ran the EOI that you all know about. We had over 5,000 applications. The immense majority of those, 4,700 out of those, just over 5,000, were eligible to meet the requirements, which was no surprise because the requirements are very similar to our CGP accreditation, and the rollout was, at least for this stage, limited to accredited practices. So the immense majority of practices were deemed eligible and they received letters last week. from the department via the PHNs. Now we are committed to make sure that all those practices have the chance to deliver the vaccine. Of course, practices can change their mind and withdraw from the program or decide to pause and reconsider at a later stage. But we want to make sure that every single one of those eligible practices that wants to participate in the program gets given the opportunity to do so, and gets given the opportunity to do so early on. So we are now committed to commence the rollout from the week of the 22nd of March, which is as we plan from mid to late March, and then bring the practices on board very quickly over 4 weeks, so that 4 weeks after the program commences, all eligible practices are able to deliver the vaccine and do so across the geography of the country. In order to do so, we have to do it in a staggered manner. We can't go to 4,700 general practices, the GP respiratory clinics, and the Aboriginal Community Control Health Services all at the same time. We'll need to make sure the logistics work and that people can receive their doses on time, their stock on time. So we're doing a staggered rollout with around 1,000 practices being brought on every week until we have completed that full rollout of all the eligible GPs. Later this week, and probably between tomorrow and the day after, practices will all receive, all eligible practices will receive an info pack that will confirm, once again, confirm their eligibility, give an indication on which week of the rollout they will be participating on, and give an indication of what doses they will be offered, at least for the first 12 weeks of the program, to be able to deliver. Again, we're not making impositions on asking practices to deliver more doses than they're comfortable doing, or committing the practices to a particular throughput that then they need to deliver for the following 6 months or anything like that. We will offer the practices a number of doses per week that will never be higher than the throughput that they estimated as part of the application, and then the practices can choose whether to participate or not. Obviously, since we're going to a lot of practices across the country, and we're going to a vast majority of the accredited practices and the immense majority of the practices that applied, the actual number of doses available in each of the practices themselves is not going to be enormous. We're not going through a mass vaccination type of scenario. We're going to, because that would be fundamentally disrupting how primary care works, to create something different, a sort of mass vac scenario, whereas if we go into primary care, it makes more sense to play on the strength of primary care and allocate fewer doses for each of the practices, but in a way that is less disruptive to how our general practice normally operates. So we will send those letters via the PHNs in the next couple of days, confirming which week of the rollout the practices are, which doses your will be offered to get throughout those first few weeks of the program, and a fairly comprehensive onboarding pack that will include a lot of the answers to many of the questions that we keep being asked in terms of how to order stock, what consumables will be included, how what are the dimensions of the boxes so that you can plan for your fridge, as well as other practical implications, other practical indications, as well as all the links to the ATAGI advice, the pro forma consent form that can be used if required, the training modules, all in one place so that you can have the one document that gives you all the information, including more granular advice from ATAGI on which chronic conditions determine 1B eligibility, because we know that what's currently available on the website is a little bit vague, like what inflammatory disease conditions are we talking about, what is the range for hypertension. So all of that will be made available with the onboarding pack that is going to be sent to the practice in the next couple of days. And then, of course, those elements of clinical guidance like the ATAGI advice will be published on the department's website, but we want to make sure that we give you one place where you can go to as your sort of program guide for the rollout in primary care. I probably could talk for half an hour more, but I'll probably just shut up so that whatever I talk about is more focused on answering the questions. But so yeah, I'll stop at this.
Great, thanks, thanks, Lucas. I will hand over to Jeannie, who's going to facilitate the questions. But Jeannie, we do have one hand up. I think Sheila's got her hand up. Not sure if you had a question you wanted to ask, Sheila. I can see you've come up, but I think you're on mute at the moment. Can you unmute, Sheila? We might go while you're working that out. Can you see the hands up there, Jeannie, in the attendees bit?
I can't. Shall I leave that to your capable hands, Bianca, and I might start working through the questions that I've got.
Yep.
Lucas, you mentioned, well, firstly, we've got some fantastic questions here, and I just want to reinforce to everyone that if we don't get through all the questions, including these ones and the ones that have been sent in beforehand, we will be making sure that all these are answered and circulated. So you mentioned that in a couple of days, we're going to find out a bit more about eligibility for 1B. And one of the questions is, what proof will someone need to kind of prove their 1B eligibility, especially if I'm vaccinating someone coming from a clinic that's not my clinic where I have that record there?
Absolutely. So the onboarding pack and then the information we'll publish online will have far more information on all of this. But essentially the answer is it will be a range of options so that we make it as easy as possible and we don't generate new barriers. We don't expect the general practices to be police people. Like that's not the approach. And like any eligibility for any clinical program, like whether we're talking about whether you can get CTG or others, if the practice is satisfied with what the patient has provided, that's enough. And then they just need to record under that you know, they were eligible under this or that category. So we don't expect the practices to do a forensic examination of documents to determine whether there's fraud or not, just to satisfy themselves that the person is broadly into one of those categories. And and the document will be providing specific advice on which, on what ways eligibility can be attested for each of the categories. Some of them are pretty straightforward, like occupation-based categories can be attested with a letter from the employer, or if it's for a healthcare worker, with APRA registration or a contract or a pass from a hospital. Like there's anything that satisfies, that gives you comfort that that person works where they say they work. A letter from employer is the most straightforward for that. Age, if the patient is in your records and you have the age, that's it. Anything that has their age on there, you know, a proof of age card or any other form of identification that shows date of birth and gives you an indication that that person is eligible based on age. For Aboriginality or Indigenous and Aboriginal Torres Strait Islander status, we specifically ask the advisory group, Aboriginal Torres Strait Islander advisory group on COVID-19, what was the preferred approach, and self-identification is the preferred approach. So the pack will also have a guide, some guidance on, which is consistent with RCGP and AIHW guidance from before, on making sure that we ask every patient that comes to the practice whether they are of Aboriginal Torres Strait Islander origin, and if so, well, that's enough to then record as eligible. For underlying conditions is the one that we probably needed to provide the most guidance, because as I said, they were a little bit vague. They're a little bit vague in the way they're listed. So the pack and the online information will provide specification of what we mean by those conditions and what more granularity on what it's included and what isn't. And then in terms of attestation, anything again that satisfies. So of course, a GP referral or a health summary from IHR would be ideal, but we don't want to make that the only way, in case that creates another barrier to access if someone needs to get a non-bulk bill consult from their GP to get the referral or something like that. So your patient, if someone's a diabetic and the insulin script, or any other, if it's from one of the cancers, a report from their oncology appointment. But ultimately, we're also, and we'll make this explicit, we're also providing a non-stat declaration form that the patient can fill in if they don't have any other way to confirm that they have their chronic disease and they want to attest that that they're eligible under that section. So we will provide a range of ways in which that eligibility can be attested, but we really need to emphasize that we don't expect your clerical or reception staff to be policing this, just to make sure that they have a guide, that they're supported on how to attest, and then that their eligibility is recorded.
Thank you, Lucas.
Jeannie, sorry, just to jump in, we've got two what look like live questions. James Bishop, got a question? You can unmute. No, seems to have been a Jan. You've got your hand up. Is that a question?
Can you hear me now?
Oh yes, James can do.
Sorry. Yeah, it was just Dr. Lucas just mentioned there'd be one place to get information. I was just wondering if you could detail exactly where that would be. Pretty please.
Yeah, so in general, health.gov.au has a vaccine hub where all the information, including provider information, the pro forma consent forms and clinical guidance from ATAGI, all of that is uploaded. And that's, we recommend people go there, health.gov.au on the vaccine area, and you can register your email so that every time we put in new updates, you get a notification. A lot of information is always available through your PHNs. And I know both Eastern Melbourne and Northwestern Melbourne are very proactive in this space, but the document where we're trying to put everything together, noting that it will only be current for a few days because things move quickly, is the onboarding pack that all practices will receive in the next couple of days as part of the next round of letters that we're sending them. We got a bit of feedback and we're just moving as quickly as we can with the environment, but we got a bit of feedback that some practices were a bit disappointed with the letters that we sent last week that just confirmed eligibility but didn't give them much else. So we want to make sure that the letters that we're sending in the next couple of days have this onboarding pack attached to it that has a lot of more in detail information, including the dimensions of the boxes and all those things. That onboarding pack is not going to go online initially because it has unique links to registration forms and ordering forms, but the relevant information that is clinically relevant for everyone from that onboarding pack, like the eligibility, the granularity on the eligibility, or any of those questions, will be uploaded on the department's website in that vaccine hub.
Thank you.
Jeannie, we might flick back to you for one of your next questions.
Excellent. Thanks, Lucas. You talked about occupational groups being able to attest to their 1B status. One of the questions is about our practice team. Can you confirm that our support staff, including reception staff, are included in 1B and that we should be getting on and vaccinating ourselves as soon as we get the vaccines in the building?
For the first part of the question, yes. The healthcare eligibility is for locations. So all the staff in the practice, clinical or not, would be eligible under 1B because it is the healthcare setting and that interaction with clinicians. So yeah, your non-clinical staff in the practice are also eligible under 1B. I cannot tell you how to or when to vaccinate yourselves, but if your practice is delivering the vaccine, the moment 1B commences, your practice staff will be eligible. So whether you go through those vaccines first to your staff or do a bit of 50-50 or book in some patients and then do your stuff, we're not going to tell you how to organize it. But 1B eligibility kicks in at the same time across the priority groups.
And I've heard advice that we should stagger vaccinating our staff in case people feel unwell the next day.
I mean, this is. I'm trying not to get too nerdy here, but it's really interesting. We're not seeing as much. It's super early, but there's been about nearly 50,000 vaccinations happening in Australia already, and we have been very careful with the vaccination of residential aged care facility workforce, so that we don't go vaccinate everyone at the same time and then they're all off with adverse events. It will be interesting to see how the adverse events play out in our context where we've had such relative low prevalence of COVID, and I'm putting this with every inverted commas because I know especially the Northwestern Melbourne PHN catchment area was the epicenter, and Eastern Melbourne a fair bit as well of the resurgence. So I'm not minimizing your experience at all, and I should have said it at the beginning, I'm super grateful for what you guys went through and how you dealt with the resurgence. Like we were all rooting for you, and we will always be grateful for what you did. But if we compare ourselves with the experience elsewhere where there's incredibly high prevalence of COVID-19 in the general population, it makes sense that we would see a more florid presentation of adverse reactions, given that people are getting the vaccine with prior clinical or subclinical COVID infection, and they would have developed some immunity to it, so probably more prone to infection. We know to reactions. We know that particularly in Pfizer, their second dose seemed to give more adverse effects than the first dose, which again, immunologically kind of makes sense. So it will be interesting to see if in a very low prevalence environment, the nature and the intensity of adverse events is a bit lower than in other countries. However, in general, it's not a bad idea to stagger in case that happens. We are not seeing enormous, like significant adverse events requiring people to take the day off. We have not seen that a lot or at all in across the workforce that have been vaccinated yet. But in general, it's probably a good idea just in case to have that stagger so that not your entire practice, if they're going to have adverse reactions, suffers at the same time. I think that's a pretty sensible way to go about it. Sorry, I should give shorter answers so that we can have more questions.
Lucas, there's a couple of questions about who can physically do the jabbing. One is specifically about non-GP specialists. So this person is they're doing a clinic, and they've got some non-GP specialists volunteering to help give the immunisations to help with the after-hours mass vaccination clinic. Plan is that the GP is overall responsible for the clinic and for the cold chain and for consent and for supervision, but that some non-GP specialists will be doing the actual jabbing, but they've been told by their MDO that they won't get indemnity, essentially because of the from what I can tell from the question, it says MDOs are denying indemnity to many non-GP specialists, not scope of practice, after the Brisbane GP was sued. Do I interpret it that's only if that person is doing it without the supervision of the if the GP is providing supervision, then that shouldn't be a problem. That would be my interpretation. But I wonder about your interpretation.
Look, and I think, as always, we need to caveat these answers that we're not providing individual medical legal advice. And for any questions, please go to your MDO. There's several parts to this question. So, one that I need to pick up on is the mass vaccination clinic after hours. General practice are not going to receive, and I think we need to be clear because there will be some disappointment in people who are expecting like thousands of doses a week to do mass vac clinics. We're going to 5,000 points of contact between GPs, GP respiratory clinics and ACHOs very quickly with a limited number of doses coming up. So there's not going to be a lot of mass vac capacity across the system. Even in the practice that will get high dose allocation, we're still talking about a few hundred doses, not thousands a week. So that caveat there. Who can actually jab? The answer is anyone who is authorized within the scope of practice and relevant state and territory legislation and to immunize and has completed their mandatory online training that the Commonwealth provides is authorized to immunize. For MBS purposes, their overall responsibility for the service and the claiming needs to be under a GP or other medical practitioner, depending on what the items that are claimed. But in terms of whether other non-GP specialists, nurses, Aboriginal health practitioners, or Aboriginal health workers in some settings are authorised or not to actually do their physical jabbing, the actual administration, that's really going to be conditioned by what the scope of practice of that particular professional is in the context of the state and territory authorization, legislation, Poisons Act or equivalent for who is authorized to immunize. Noting that there's been some emergency determinations made in some jurisdictions that broaden the eligibility of immunizers in the COVID-19 context, but it does vary from state to state. And having completed the online training, what the implications for that are for that in terms of medical legal cover for that particular practitioner, I think that needs to be discussed between the practitioner and the MDO.
And so speaking of that, sorry, Bianca.
Jeannie, I was going to say we've probably got, in the interest of time, time for one more question, and we'll move on, and hopefully we'll have some time again at the end.
So quick question, Lucas. Speaking of that online training, are the rumours true that there's going to be a more truncated GP-focused or GP clinic-focused training module that we'll be able to do for the GP rollout?
Yes and no. So the rumors are true in that we are receiving a lot of feedback on the modules, and the colleges have been quite forthcoming on with their feedback as well. And we are looking at improving them, upgrading them, and sort of a CQI approach of making them better. I'm not sure we will have a GP specific one. We could atomize and make specific training packages for a lot of different professions that are involved in the multidisciplinary team in primary care. And then ensuring consistency between those and currency of those as they're updated becomes a challenge. But we are definitely reviewing the assessment and the way the questions are formulated, and looking at upgrading and doing a few upgrades to streamline them somewhat in the next few days or weeks. However, I strongly recommend that everyone who wants to be involved in especially the early phases, or expects to be involved in the early phases of the 1B rollout, completes it. It can be a bit tedious at times, but it does have a lot of information. I did it last night, and it does have a lot of really valuable information for the rollout. It does have it can be repetitive at times, but it's absolutely mandatory. I wouldn't wait until another version comes out. I would just go do a module a night. And you get through it in a week.
Thanks, Lucas.
So someone has put a question in the chat that if we were to answer all these questions, we'd sort of be here till midnight, which is a very fair point. So we will cut it off at a point, but I encourage you to keep putting your questions in the Q&A, so we'll be able to get a copy of that. No, there's lots of interest and lots of questions, so we might be working with you over the next couple of days, Lucas, just to finalise the answers to those. So I do want to reassure people we'll be getting back to you with the answers. We just might not have time tonight. So thank you for that. And as I said, we might have some time to circle back to some questions. I do now just want to hand over to Janine from the Austin and Finn from Western Health to give us a bit of an overview of each of the sort of hospital hubs and the role of the hubs and the public health unit and the vaccine rollout. So Janine, not sure if you want to kick off first from an Austin perspective.
Yeah, thank you very much, Bianca. Hi, everybody. Who doesn't know me? Dr. Janine Trevillayan. I'm an ID physician at the Austin Hospital, and I'm the lead of the Austin Vaccination Hub. I'm sure you're all largely aware of how that works. So essentially, we were set up for originally for Pfizer as that was coming through, and that was because, as Lucas has mentioned, you know, the issues with cold chain and needing ultra low temperature freezers means that you really do need a tertiary level pharmacy to hold those sort of, or to deal with those sort of vaccines. So that's why that process happened. For the Austin Hub, the way we've planned to do it is by collaborating very closely with a number of the other large public hospitals in our area. So St Vincent's, Eastern and Northern Hospital. And the four of us have then kind of worked out, you know, again, collaborating out around our areas to the other smaller public and private hospitals around, and now starting to reach out to the GP respiratory clinics, the community screening clinics, those sort of other 1A groups that live outside of a hospital. Obviously, a large proportion of the 1A exists inside hospitals. And then each of those centres that here through the Austin Hub are in the process or have set up vaccination clinics. And they're really starting now and then escalating in number. So you may have heard that, you know, here at the Austin, we started our first clinic last Monday on the 22nd. Our second larger clinic will be opening next week. So that's at the REPAT down the road from us here in Heidelberg. And then the other public hospital clinics are also opening either later this week or at the start of next week. Doing sort of slightly soft starts, trying to get their feet, making sure that all the processes are right, and then escalating in terms of access to vaccination for all of those kind of 1A groups. So for instance, here at the Austin, we're doing a lot of the VicPol staff, a lot of hotel quarantine staff, and then 1A healthcare workers is really what we're looking at the moment as we roll up. And it's really just a logistical sort of thing from us in terms of handling the Pfizer vaccine, defrosting it, getting it out to the other hubs and getting it into people's arms, which is the key. But obviously all of those sites are also being set up to deal with AstraZeneca as well. And the plan is really that these will be some of the centres that will be able to provide access to large kind of vaccination volumes for staff and patients and the general community. I suppose the other thing to mention is that there are in Victoria 6 hospital-based sites for vaccine allergy. So I know I get lots of questions about, can this patient have Pfizer or should they have AstraZeneca? They've had this allergy. And so one of those allergy clinics is being set up here at the Austin, so that people who are possibly not suitable to have Pfizer, it really is only a very small proportion of people who've had really anaphylaxis to a vaccine in the past, that they would get assessed by an allergy specialist. So there's those sort of services being set up as well at the moment. And I might stop there and we can keep moving to Finn.
Thanks, Janine.
Hi, colleagues. So my name is Finn Romanis, Public Health Physician and Director of the Western Public Health Unit, WEFU. So briefly for 10 seconds, just to say who we are now. We're a unit covering about 53 or so postcodes, 10 or 11 local government areas, and we've got a growing public health team of about 20 FTE staff that will be increasing. At the moment, we're largely focused on contact tracing for COVID, and that will expand to outbreak management over the coming period, and then into broader communicable disease control. The Western Public Health Unit's involvement with vaccination is relatively limited due to our focus on contact tracing, but clearly Western Health is working with partners in Melbourne Health and other health services to provide for vaccination through hubs. So clearly, as has been said before, focus on border staff and hotel quarantine staff at the moment, vaccination out of the airport through Western Health and Melbourne Health, and the Sunshine Hospital Hub is opening from tomorrow, from about 8 till 4:30 tomorrow, to focus on hotel quarantine staff, and then the following days focusing on a range of 1A staff. It'll be about 60 cubicles or so, operating 12 hours a day, 7 days a week. So the focus on vaccination for the Western Public Health Unit, which is that public health unit within Western Health, will turn to matters such as the promotion of vaccination, problem solving and troubleshooting around vaccination, and eventually over the course of the coming months to how vaccination affects contact tracing and outbreak management, and how we then work with you to adjust that arrangement. So lots of activity, and that's the brief overview.
Thanks, guys. Are you happy for me to throw some questions at you now? There's been a couple of questions along the same theme, and it's a little bit about how people book in, if they're 1A eligible, how they book in to a vaccine clinic at one of the clusters. But then there's a little sub-thread question about the patients who are not Medicare eligible, so are not particularly practical for us to vaccinate at our clinics, and we understand that your hubs will be able to help us with those non-Medicare eligible people. So how does someone ring up the hub and say, hey, I'm wanting to book in for a vaccine, please?
I would love to ask Lucas to answer that question for us of how does the general public get into the vaccine system and how do we process that? I think we don't know exactly how that process is going to work here in Victoria. That's different to the 1A group. I think that a lot of those groups are being identified obviously through their employers. Obviously 1A is really an employment category. And so what is happening is that employers are developing lists of their staff who are suitable for vaccination, and that's being distributed across the hubs based on geography. And so that may not be completely convenient, unfortunately, for the staff involved, because based on where you work, not where you live, but nonetheless, that's sort of the way that works. So for instance, here at the Austin, as I said, so we've got public screening clinics around us, and so the managers at those staffs at those sites are sending us their staff names, and then those people will get an invite email to say, hi, your time's come up, we've got enough vaccine now, we're moving into your group, so please feel free to email or call us up or log on online and book in. So yes, the other thing, so from a Medicare ineligible, obviously a Medicare ineligible staff member, we will just vaccinate those when the time comes, and we're vaccinating the general community. Yes, at the Austin, at any of our sites, we're very happy to vaccinate someone who doesn't have a Medicare card. How they get into the system and how they get to us is not yet clear.
And Janine, the invites that you're talking about, so for GPs who are eligible for 1A, which is the GPs working in our ACFs, My understanding is that the PHN is collecting that data, and that they will start getting invites to come and get their vaccine.
Yes, sorry, yeah, I mean, I just used a screening clinic just because I can sort of almost half see one out my window, so that's sort of what came to mind. But yes, that applies to, yes, pathology centres, GP respiratory clinics. Exactly that same process has happened. I'm sure the Western and Monash are doing something similar, but so at the Austin, we've been reaching out to the people in our area and sort of saying, hi, you know, give us your staff details, and that puts them in the system. And yes, the Public Health Network groups have been really helpful because of the connections that they all have in helping put us together.
And another question that's come up a couple of times, which I know that Janelle has answered on the chat, but in case people didn't see it, is about those of us who are GP testers but aren't at GP respiratory clinics. And unfortunately, the Commonwealth have deemed us to not be technically 1A. And so us testers who don't work in a GP RC will not be getting invited to be 1A. And lots of nods, and we know. And,
that's my understanding.
That's
You're right.
Not
our decision necessarily, but that is. And I think, to be fair to the Commonwealth and the state, you do have to sadly draw a line somewhere. It's based on modelling and risk, but then also sometimes a line, you know, within the hospitals, we've had to draw lines about who is and isn't a 1A hospital worker, and that's not been easy. And I agree that the thing that I hope, as Lucas said, we get large volumes of AstraZeneca coming out of the Broadmeadows labs, and there will be very little difference between who's 1A and who's 1B. In fact, I'm hoping, well, obviously for some people the difference will be 1 day, but I'm hoping for most people the difference will be very, very small.
I've got another question that's more of a kind of clinical question about the vaccine. I'll just read it out verbatim. It said, what is the gap between flu and COVID vaccine? The UK says 1 week. ATAGI says 2 weeks. The training pack says 1 week. The question's marked you wrong if you said 1 week instead of 2. I understand the advice is 2. And everyone's nodding, so we confirm that it's 2.
Well, so just to be clear, the reason why the spacing is recommended is mostly so that because there's the new vaccines, we have full understanding of whether adverse events are related to one vaccine or the other. The preliminary advice was 14 days. Then that was refined into probably between 7 and 14. So now we're going to that between 7 and 14, but for simplicity, it's basically with 2 weeks, which with AstraZeneca makes it really easy, because with that large spacing between first and second dose, it's less relevant to be, it increases the chances of being able to have other vaccines administered in between the first and second dose. Whereas when we were thinking of a 4-week dose, or the Pfizer 3-week 4-week interval, or the Pfizer 3-week interval, then it was actually much more relevant whether it was 7 or 14 days. Generally, more than 7, around 14 is a good spacing between them. But given that there are 12 weeks of space between dose 1 and dose 2 in the primary care context that will be administering the AstraZeneca vaccine, it becomes less important.
And that's across all vaccines, Lucas, not just the flu vaccine. It's all vaccines are recommending the 2 week. There's not different gaps for different vaccines. It's just the 2 week recommendation.
7 to 14 days, yeah.
Yeah, sorry. There's a couple of questions about vaccinating the frail elderly who are housebound. And I guess the simplest way to ask the question is, will that cohort of people come under our own, for each clinic to work out how they're going to vaccinate their frail elderly patients who are housebound, or will that group of patients come under one of the public health unit groups? I'm not asking it very clearly, but I think you know what I mean.
Was it to me or to the public health unit?
Whoever wants to answer it, go for it.
Damn it. I guess it depends, but generally it would be included in the cohort that is vaccinated by the general practitioner. There might be different arrangements in different areas, and we will have to apply different strategies for hard to reach populations if while we're continuing the vaccination effort. Sorry, I'm getting 50 messages a second. We're getting further, we understand that there are areas where there might be populations that are missing out or not getting access, particularly people who don't have access to a regular GP who is part of the vaccine rollout. But generally, if you're part of the vaccine delivery program, you have someone who's eligible under whichever phase from 1B and who you think should receive the vaccine, and they're in your patient books. Yeah, I wouldn't assume that there will be other program that will reach to them.
What about if I'm a clinic that hasn't been successful in getting the vaccine in my clinic, and so will those clinics be encouraged to still contact their patients and still suggest places that they can go to get vaccinated?
Yes, I'm careful not to, of course, say that that's an expectation on the GP, because that also comes with funding questions and sort of duty of care, medical legal. But if that is a role that you want to play, absolutely. And there are several ways that you will be able to refer people to find locations, whether it's over the phone or online, or if you know of a colleague practice that is doing them, then referring them directly to them. So.
Jeannie, I can see we've got a live question, and we might take that and then move on to Andrew. So we've got time. Kim, do you want to take yourself off mute and ask your question? Or if we need to take you off mute. Kim, not sure if you can press the unmute button, bottom left of your screen. No, we might come back to you then afterwards. So sorry about that. Not sure why you're having some trouble getting off mute. But we might just throw to Andrew Lowe now, who is from Aspen, to talk about the rollout in residential aged care facilities.
Good evening, ladies and gentlemen. As introduced, I'm the Director of COVID operations at Aspen Medical, and we have an agreement with the Commonwealth to support the rollout of the National Vaccine Strategy for aged care facilities across Australia, less Queensland and New South Wales. What I might start by is just describing what we look like, and then narrow down to what the teams will look like that will approach and support your facilities for the vaccination rollout. I work in Canberra with a program management office, and then what we have across Australia are 8 regional managers with their teams, of which in Victoria we have 3 regional managers. Each has a metro, and they're aligned to the primary health networks, and each of those have a metro area and a regional area. So, for example, with East Melbourne, Mark Taylor, who's the regional manager for East Melbourne, is also responsible for the Murray PHN. And then for Northwest Melbourne, Kieran, he has responsibility for Northwest Melbourne and West Victoria. And that's how we manage it. Under each of those regional management teams, they've got the team leader, and then they have a regional clinical coordinator as part of their team, and then a logistics coordinator. Underneath them, they have a series, multiple vaccination administration teams, and they're the ones who physically do the vaccinating and will come to the facilities. A typical vaccination administration team has 5 to 7 personnel in it. Typically, they'll have 4 nurses. One of the nurses will be the team leader, and each of those registered nurses are nurse immunisers. At any one time, there'll only be 2 nurses vaccinating. So the other nurse will be supporting with the checking of consent, the checking of the health of the recipient, and then doing observations post-vaccination. A team may also have 2 data entries. So for each vaccinator, someone to enter the data into a system called MMEX, which links to the Australian Immunisation Register. Part of our process too is we will be scanning in and putting into that system the evidence of consent, and then also we'll print out at the post-vaccination a certificate of vaccination in hard copy that can be taken by the recipient, their guardian or the facility. And then there is a logistics person who supports that team. And the way that we look at it is if a facility has less than 150 residents, that is within the scope of one team. If a facility is larger than 150 residents, we would apply 2 vaccination teams to that facility. Our intent is to complete any facility in a single day and not to go over multiple days other than coming back for the second dose. So the way that the vaccination is being scheduled at the moment, if I sort of give indicative numbers across our area. So week 1 was very high tempo, and the original numbers that we had given as targets for the number of sites across Australia, quickly, we learned a lot, quickly became the realisation early in the week that they were not sustainable, and our number 1 priority was the safety of the residents who were being vaccinated. So the tempo has slowed, which it has done. And what that's enabled us to do is 2 things. 1, allow the Commonwealth logistics provider to be able to guarantee timely delivery of vaccines. And also it has allowed us to generate and train the appropriate teams to do the vaccination. So over weeks 1, 2, we'll have about the same. We're in week 2 now. Week 3, starting on the 8th of March, we will see a rise in the number of sites that we can go to. And then in week 4, we'll see another uptick. In week 4, of course, we will be starting the second doses for all those facilities that we went to in the first site. As far as scheduling is concerned, we are working on today on week 4. So that's the week starting, Monday, the 15th of March. That hasn't been established yet. We'll have that out to the Commonwealth this evening or early tomorrow morning, and then we will distribute that program out to the PHNs to support the facilitation of information. Our regional managers also get that information, and that's their trigger between themselves and their vaccination teams to start ringing ahead to the facilities. In a normal pattern, what is ideal for us is that we're giving you a call 2 weeks out, and that where possible, particularly in metro areas, we're doing a site visit 7 days before vaccination. That allows our teams to talk to you and work with the facilities about where we would conduct the vaccinations, how we'd like to conduct the vaccinations, the flow, any support that the facility may require. And then also what it will allow us to do is to confirm how the consent is going and what the indicative numbers are for that facility for residents for vaccination. At the moment, over these first couple of weeks, we are using historical data that the facilities have provided back in December last year. So we're not able to change those, but in the future, when we confirm with the facilities, working with the PHNs, we'll be able to get a surer number, which will allow us to make an immediate order 7 days out to the Commonwealth logistics provider to deliver the right number of vaccines. And that will go to reducing instances where we have under the number of vials that we need or over the number of vials we need. But both are problematic, and we wish to reduce that and ideally improve the efficiency going through. And then also for weeks 5 and 6, we'll be planning that this weekend. So we're trying to get ahead of the curve here. The rollout, the agreement that Aspen Medical had with the Commonwealth was for a 12-week rollout for residents and staff of aged care facilities. Because we're only doing residents at the moment, that 12-week window will need to be revised. We're not privy to that, but from a sheer mathematical exercise, we won't fit in all using the current model, all residents and staff in that 12-week window. If I then go to looking at what the responsibilities are, and if I look at what the facilities are responsible for and how we look to work with you, for vaccination day, the number one responsibility is obtaining and confirming consent. Our vaccinators come in and check consent. We're checking for the evidence of consent, but the responsibility is on the facility to gain it. Ideally, the consent form that's on the health.gov website is perfect because it asks the right questions and has the right detail in there that we can use to confirm, we can use to check consent. On there, it talks about allergies as well, which is useful for our vaccinators. We also note that form though we've experienced has a spot there for the Medicare number, but it doesn't have a box for the index number on the Medicare card. So in that, what we ask is if you know what the Medicare card index number is, please write that in. But what we've had some instances where there's been an assumption on what that number is, and it has created confusion because the name doesn't relate to the Medicare card index number, and it might be someone else in the family. So that takes time to resolve, and it's not necessarily time that we have on the day to sort out. And all this needs to be uploaded into the Australian Immunisation Register through the portal. The second thing we're responsible for is the facilitation. So providing the space or support for the vaccinations. And that's just area, tables, chairs and the like. We know and appreciate that each facility varies in capacity and capability. Ideally, those common areas are perfect for conducting vaccinations. It allows for a flow of from residents to come through. It also allows people to be held in waiting areas that can be commonly observed. So if they stay in their rooms, it is difficult for our vaccinators then to be able to have their duty to observe it 15 minutes post-vaccination. So if in those common areas we set up an area, they sit for the 15 minutes and we can observe them, and then after that 15 minutes they can go about their day. Of course, we appreciate there are immobile residents, and for those instances we will go from room to room, but where they can move, that centralised area is ideal. The third area that the facility is responsible for is post-vaccination monitoring. So the policy that we have been given as the vaccine provider is that we are responsible for monitoring and for responding to and reporting adverse events until 15 minutes after vaccination. Of course, whilst we are there, our vaccination teams had adverse event kits. They are anaphylaxis trained, they're nurse immunisers. So if something occurs whilst we are physically in the building, our professional role will kick in. But after that last recipient, it's 15 minutes, and then that responsibility goes to the facility, which from our perspective is no different from other vaccinations or the other support that you have after hours. What we are responsible, so the Aspen Medical vaccination teams that come in, firstly, we're responsible for the cold chain management. So the Commonwealth logistics provider will deliver what's called a cool green box. It's a cardboard box to the facility, and they are meant to sign it over to the team leader, immuniser of our teams, and only to them. It is getting better, but there are instances where it's left at reception or just left in the foyer and the like. That is not the process. We ask if a box is given to reception by mistake, or a box is delivered to a facility in error on the wrong day, don't open the box. when the box is open, it's sensitive to shock, it's sensitive to light, it's sensitive to temperature, and it has a thermometer in it, which is Wi-Fi connected to the Commonwealth logistics provider's central hub. If there is a breach in that cold chain, then there's a process that's gone through, but it can become difficult to guarantee the integrity of that cold chain. So the Commonwealth logistics provider and ourselves as the vaccination provider are responsible for the cold chain, not the facility. We come self-sufficient with eskies that we pack in a certain way, that when we take the vaccines out of the cool green box from the logistics provider, so we can maintain that through the day and move from site to site using those eskies. We are not responsible for nor resourced to store vaccines overnight. That is the responsibility of the logistics provider. So, and nor are your facilities. We won't be coming in asking to use your fridges. We come self-sufficient. We won't be coming in to ask your syringes or other consumables. We come self-sufficient. If there is a breakdown in our own logistics chain, in some instances, the facilities have been quite willing to support us to get the vaccinations going, and we appreciate that. That's not our model, but when it does occur by exception, we are responsible to either compensate or reconstitute your stocks, because we are responsible to come self-sufficient to your facilities. I talk about under and over vials. In some instances, the wrong delivery has been made with the not sufficient number of vials. There is a process we call the Commonwealth Vaccination Operations Centre, and then they liaise with the hubs about what might be available to get to that facility, so we can continue to vaccinate the number of residents seen. Also, in instances we have had excess vials at the end of the day, we then enact the excess dose policy, which I'll outline briefly. But again, if there are just not enough recipients to receive the vials that we have, we then call back to the Vaccination Operations Centre, and they coordinate direction for its use, ideally backload through the logistics provider back to a hub. We have, in the first couple of weeks, last week and this week, have experienced in most cases a number of excess doses being available. While we have an agreement to do the residents at the moment, the excess dose policy that we follow at the moment is that if you've got respite residents in your facilities, they are eligible if they, going through the normal consent process and the health checks. They are respite residents can receive excess doses. Our own vaccination teams are a priority as well, as they're going into multiple facilities across the country over a long period of time. Then there is the staff of the residents, and those staff. I note that the Commonwealth has put out a definition of staff in phase 1 alpha of the strategy rollout for aged care facilities, and that relates to the nursing and personal care staff, allied health professionals, and then any staff associated with the facility. So it mentions specifically kitchen, cleaning, laundry, garden, and office staff. We're not the gatekeeper. If the facility says they're on staff and they're volunteers and they meet the consent and all the remainder, the health checks, then if we've got excess vials, we will vaccinate. General practitioners and other health professionals who routinely provide care within the residential facilities are also deemed as staff according to that latest information that's on the health.gov website. I might pause there and ask for questions. Thank you.
Thank you, Andrew. Can I just clarify? You're talking about the staff getting vaccinated if there's excess doses. Otherwise, they are part of 1B and will get vaccinated, or are they part of 1A and go to the so how, I guess the question is, the staff that aren't getting vaccinated with the excess doses, how are they going to get vaccinated?
Yeah, so Aspen Medical has an agreement with the Commonwealth to vaccinate aged care residents and staff. However, at this point in time, we've only been directed to vaccinate residents. When the staff will come into that model, we're yet to be told. So how the staff are vaccinated.
Hi, Andrew, I might take this one.
Yep.
So as Andrew and I outlined, the approach was always to do residents and staff. With the early first few weeks of 1A, and noting that we want to ramp up quickly and make sure that we get through as many residents as possible, because they're the really high risk of severe disease. We've asked the providers, such as Aspen, to prioritise the work on the residents, and we're finalising the arrangements on how a range of strategies will be applied for the prioritisation of the workforce. That's why today the vaccination of the workforce has been a little bit ad hoc with any remaining doses, as Andrew outlined, but that's not the end of how we expect the aged care workforce to access vaccination. We're looking at a number of solutions. We just wanted to make sure that, especially in this first couple of weeks of lots of a quick ramp up and lessons learned, etc., we could focus on a rapid vaccination ramp up for the residents who are highest risk, and then we'll bring in strategies to make sure that we catch up on the workforce.
And presumably, Lucas, that also means getting the second dose to those staff who were given some of those mop-up doses. Yeah,
that is correct. Yeah.
So maybe I can. So our approach is, if you received the first dose from our vaccination teams in 3 weeks' time at the same facility at the same time, you will get your second dose, regardless of who you are. So if we've given you a first dose, we are responsible for giving you a second dose, and it's an automatic booking, as it were. Now, look, our approach is 3 weeks out, as long as we've met the minimum 21 days to the gap. That's our approach. Now, there will be over Easter, because some of the days, Good Friday, Easter Monday, for example, we won't be booking in returning to a facility on those days. But so it might be 21 days, it might be 3 weeks plus 2 days when we reschedule in. But as close as we can, that's what we're looking at, returning to those facilities. And we know exactly how many vials or doses we'll need, because it'll be exactly what we had in week 1.
Andrew, there's lots of questions on the Q&A about consent, and particularly about the role of GPs in obtaining consent. We had one comment that one facility was insisting that the GPs were involved in consent for all of the residents, which is quite an impost on GPs who are obviously having other work to be doing. Can we get some clarification about the roles of the GP in obtaining consent?
Yeah, so I'm not a clinician up front. What we advise our nurses is they need to check consent has been made. Now, if a resident requires GP support in making that decision, or whoever is making that, who has the consent authority requires GP advice, then we expect that has happened. This is why the consent form, as it's standard, is on the health.gov website, is ideal for our vaccinators. We note that it's not mandatory, and we note that some other facilities have their own, and we have instances of that today. But essentially, if there is a form of consent that we can confirm, or we can check that it's been confirmed, that's what we require. Of course, our vaccinators are making an assessment on the health of the recipient at the point in time of vaccination. But in some instances, for example, clinical notes can constitute as consent, and that would be evidence enough for our vaccinators. However, on the other extreme, just a list of names that said the following residents have consented would not be sufficient.
Yeah, so I think what you're saying is it's kind of facility by facility are deciding how they are going about getting that consent.
Yes.
Okay. Couple of questions, and I'm not sure if this is a question for you, Andrew, or a question for Lucas, but about disability residential services, where they fit in terms of the rollout, plus the complexity of consent, obtaining consent from that client group.
So disability residential services are also part of 1A, and they're being rolled out as we go. I think don't want to. I was trying to see if I could find where this has already commenced, but yeah, it is being arranged as part of 1A as well, and with an enriched model similar to residential aged care.
Yeah, and I can add to that. As for medical, we did 8 disability centres in week 1. We're going to do a couple more on Friday, but that was really to learn the process. But as you would well know, and we're appreciating the nuances with it. So, for example, a 5 to 7 person team is not suitable to go into someone's home in a disability centre. So it's probably, just be a vaccination pair that might go in, but all the infrastructure and all the cold chain management and the clinical governance that goes around the aged care rollout is the same for a disability centre. So whether we have an aged care facility with 300 residents or a disability centre with 3 residents, it's the same infrastructure and framework. So it is going to be a very deliberate, our approach. And again, we were just in a trial period. The government is yet to roll out what the final work order will be for that and from which provider, but it will be a long, deliberate process is our expectation.
Jeannie, I was just going to flag, I think we're sacrificing the PHN spot. Narelle's going to wrap up for us, but if there's, so Narelle, I hope that's okay with you, but we probably got time for about another sort of 3 of the most burning questions, and I appreciate we've had a huge volume on the Q&A, so certainly can't get to all of them, but hand over to you, Jeannie, to kind of pick the final 3, and just to say Finn apologises, he's had to jump off the webinar for something urgent has come up for him.
Oh, pressure, Bianca, pressure. There's a couple of questions about mixing doses, and I see Lucas just nodding his head. Absolutely not, no mixing doses.
Sorry, did you recommend that a full course is 2 doses of the same vaccine in a clinically appropriate time?
There's a few Medicare questions, so I'm just going to ask one of them, and this is again, I'll just read it out verbatim. There's been a lot of talk about practices being able to bill a 10997 nurse item for their patients that have a care plan if they have recommended in their care plan that a COVID vaccination would assist with their chronic condition. So can we confirm that we can bill a 10997 at the same time as one of the COVID vaccination numbers?
The co-claiming rules, as outlining the fact sheet that the department published to accompany the release of the 16 Medicare items, still apply. So if the 10997 is for a nurse or health practitioner attendance unrelated to the vaccination work, for a different presentation, a different complaint, or any other different service that needs to be provided that day and it's unrelated to the vaccine work, it should be able to be claimed. Ask MBS is the best source of answers for these things, and we can send the link to that. But if it is related to the vaccine work, then absolutely not, because vaccine-related items need to use one of the 16 prescribed ones, and the rules on co-claiming, as outlined in the fact sheet, specify that any of the items that are allowed to be co-claimed, or they're not specifically excluded as being able to be co-claimed, have to be co-claimed in the context of providing a different service to the provision of the vaccine.
Excellent. I'm just trying to scroll down to the killer final question. History of anaphylaxis to flu vaccine and tetanus vaccine. How do we go with COVID vaccine in that situation?
I can jump into that. If you've had a serious anaphylactic reaction to a vaccine, you should be assessed by one of the allergy clinics once they're assessed and up and running, to make sure that you're okay to have, this is particularly just with Pfizer. Once AstraZeneca gets here, that won't be quite the same. We're not seeing the same degree of anaphylaxis with that. But the advice would be to probably get assessed by one of those allergy clinics here that will be running at that time. They're not up and going yet, but by the time we're into 1B and patients, they will be.
Just to flag, I was just badgering Janine on the chat about some details for those, and they're on their way. And when they're available, they'll certainly be added to health pathways as well. Yeah. Great. Thank you, Jeannie. I will hand over to Narelle now, one of the exec directors from Eastern Melbourne PHN, to finish us up. Just might need.
Yes, just unmute myself. Thank you so much, Bianca. Thank you for emceeing today. Look, what a great evening. I think we've reached about 380 attendees at our peak, although I see a few people are dropping off. Now, so look, lots of questions with great common themes around navigating access to vaccines, record management and consent, workforce eligibility, and managing the vaccination needs of certain cohorts of patients, especially hard to reach patients. So really great questions there. I think we have somewhere in the order of about 73 questions still yet to answer. So we will endeavour to work through these questions, perhaps a bit thematically, so you're not left with a document with 73 unanswered questions, and provide updated answers to all our attendees. Thank you so much to our speakers tonight, to my colleague Janelle Devereaux over at Northwest Melbourne PHN, to Dr. Lucas Toca, Finn Romanas, Janine Trevillayan, and a huge thank you to Dr. Jenny Knapp for wrangling our town hall questions. You did a great job. Just a few reminders, please do check out the health pathways and the new pathways that have been released there. It's an invaluable resource to GPs in navigating new pathways. Please also look out for the recording of this webinar on the PHN website. We'll get that up as soon as we can. But also there is the recording from last week about the COVID vaccine clinical focus website if you didn't attend then. This is a rapidly evolving space, and there is information coming out quite frequently, and both the Commonwealth Department of Health, the Victorian Department of Health and the public health units are utilising the PHN's communications channels. So please stay tuned to our up and coming communications. And if you are a GP practice that's submitted an EOI, please monitor your nominated EOI email address. For communications. Yes, Lucas, I got that in because I believe there is some very important things coming out quite soon. So let's make sure that we're keeping an eye on that. If you think you should have received something, please always contact your PHN to your practice or provider support team, and we'll attempt to help you navigate. Thank you also to Andrew for speaking, and I think Mark, we might not have given him a moment to chip in there, but Andrew, thank you for updating us on the residential aged care facility space. There is an awful lot happening in that space as well. To all our residential aged care facilities in attendance or GPs that visit aged care, the PHNs are doing an awful lot of work trying to support Andrew and his teams in the rollout. If you have any questions, again, please contact your PHN through to either your GP support team or the residential aged care people, and we'll attempt to help you. Bianca, I think that's about it. Is there any last messaging?
No, I don't think so. Just thanks again for everybody who attended, and sorry we couldn't get to all the questions. We did know that was likely to happen, but a great way to have those collected, and we'll absolutely be trying to turn that around for you quickly. And so just a heads up to the panelists, we might be coming back to you for some specific answers to those questions. So that would be great if you could work with us on that.
We might try and theme them a little bit. I think, Jenny, you did a great job, but I can see there is some common questions about some common issues. All right, everyone, enjoy your evening, and we'll see you next time. I don't know that we've got any future announcements, do we, Bianca, about next webinars?
No, but they are coming probably once we have all of that information you talked about that's arriving in people's inboxes over the next couple of days. I think there'll be some things to talk about after that.
All right, thank you very much. See, that's piqued everyone's interest. All right, good evening, everyone, and have a nice one. Bye.
Thanks.
Thank you.